Okay.
Thank you very much. See you later. Okay.
Okay, thank
Please
you.
send me the photo in this email. Okay. Thank you very much.
It's okay.
We start in 12 minutes, everybody. Oh my God. Oh my God. Joanna has arisen.
I realized that you were talking to me when you start with, oh my God.
Yeah, I know. Of course. Of course. I'm dressing you as God.
Of course.
Well,
How are you?
I knew you once you saw the beach, you'd have to come.
I
knew
have
that.
to come. I
I
have
know.
to come.
I knew that. Let
Yeah.
me just give you a quick tour, Joanna. Like
Okay.
this tip, this is the tip of the beach here, where it's like a dock.
It's
It goes out
gorgeous.
there. Yeah, it's really beautiful, and some high-end housing here. there's a boardwalk that goes from here all the way. This is Ocean Drive that you see in movies and everything else right here. This boardwalk goes up like 8 miles up north. So that's quite a nice walk.
Yeah.
So
Oh,
anyway,
is the beach now closed because of the situation?
no, it's nice. No, the water's nice. It's not too crowded. I mean, now, especially now, I mean, the beach is almost empty of tourism because obviously it depends on tourism.
Mm.
And like any place in the world, they're gonna have a tough time,
Mm.
you know. So how you been?
I'm okay, actually. I'm having today day off. So
Oh, cool. Great.
yeah.
So what'd you do? Do a little relaxing?
Well, I have 2 publications coming, so I've been doing those. And with PhD and home things, Christmas is coming. It doesn't feel like Christmas, but still, these
Santa
sort of
Claus is
things.
from your part of the world, right?
It is. Santa Claus
And it's
lives
from
in
Lapland, right?
Lapland, exactly. Northern Pole, there.
Now you guys are really serious about that. It's
We're
like
really
a tourist
serious.
resort, right?
It's really serious business.
And that's considered tourists actually go up there and take pictures.
You should visit, by the way, John.
Oh,
You should
actually,
definitely
I've
visit.
always wanted to visit the homeland of Grand Santa Claus.
Yeah, it's really beautiful.
Have you been up there?
Yeah, the Northern Lights and everything. It's really
Oh, okay.
beautiful. Yeah.
Yeah, that's the origin of the Northern Lights, right?
Mm, yeah.
So, we had the Spanish webcast on Parkinsonism. Tomorrow is a big one. I guess your interest is kind of in neurointerventional radiology, right?
I'm quite keen to that, I have to admit. But still, I like skull base. What to do?
Okay.
I prefer both. I
Okay.
haven't still, make thorough selection, but I'm really, it's mind blowing.
Okay. Have you heard from Pedro in Argentina? Pedro, the neurointervention. He wrote back and said, make sure you got his address.
Oh, okay. I have.
Pedro, the neuro. No, it's no hurry or anything, but.
Can you maybe send via WhatsApp or something like that? I
Yeah,
think
yeah.
I have his. Yeah.
Yeah, I got
There's
it.
no hurry. There's no
Yeah.
hurry but now that you mentioned, because it's been crazy days. So.
Yeah, and Pascal Jabor, you've got to meet him. You've met him. You
I
haven't met
have.
him
Yeah,
yet.
I know
Oh,
Pascal.
you have. Oh, okay.
I have.
Okay.
I know Pascal. He's amazing person.
Oh, okay.
Also.
Where'd you meet him? At a conference or?
In Paris, of course.
Oh,
in
that's
Link.
right. That huge conference. That's a giant
but it
conference,
was like
right?
it's enormous. Have you ever been?
No, I've seen pictures of it because
You
Lewis
should.
is kind of their competitor. Not that he's even in the same league, but I think the schools had a schism. You know what I mean? They split. I think.
Yeah, there is.
And Lewis kind of split off, and I think he's considered kind of a different, view of things. I think. I'm not sure.
Yeah. Okay.
That's just my guess.
It can be so. Yeah. In that way, I don't have anything like here in Finland. We don't make this sort of huge diversion of things. Like you can do both. You can, if you prefer, you can do skull base and endo both. But different hospital emphasize it more.
Oh, okay.
So this is how it is. But good to be here. Good to see people are coming in. There was some changes with the schedule, right?
Yeah, there was some. Yeah, there was a little confusion actually.
Yeah.
But we straightened it out, I think. We were going to have this earlier, but I had this Spanish. I had 2 people ask for a conference at almost the same time, the same country. I thought it was one conference, but it turns out there was 2.
Oh, at the same time?
No, well, one was for Saturday, one for Sunday, but I got them confused,
Okay.
So, but it's straightened out. Straightened out. Things
Okay.
like that happen. Yeah, especially the weekends. And I don't get the schedule straight. I've got to get it straight. I've got to, I haven't been busy before, so it's unusual.
It's okay. There's lots of webinars and lots of things happening at the same time.
Yeah.
So
Yeah. Yeah, there was a good one on neuroendovascular. Just had it, matter of fact, from, I don't know if you saw it, from, Salman did it. From,
I think I did. I think
Pakistan.
I did. Yeah, I think I did actually.
Neuroendoscopy.
It was really good. Yeah.
Speaking of the devil, let me make sure Marco's coming. Oh, okay. Sure. Okay, Marco's on the way. I see a lot of familiar names I don't recognize. Okay, Joanne, I'm gonna appoint you an unpaid position. Yeah, Marco's on the way in. The short registration process. There he is. Okay, there he is. Along with Al Capone. My God. We have all the Italians here.
If it was like Al Capone, it will be.
Yeah, I thought I saw Al Capone come in. I don't know, Joanna. I don't know if we should screen the visitors. We should probably check for weapons, Nick.
If Meloni is like Al Capone, it will be get lost.
There's Marco. You here, right? I think Marco. There he is. Okay. Okay.
One Capone there is, but it is Crescenzo Capone.
Oh, Crescendo Capone, maybe a relation. Marco, you there? Oh, Southeast Asia. All right. Patrin Huang, how you doing? Welcome.
He said that he's the younger nephew, Crescenzo.
Maybe. I could tell you some stories, but I won't. Okay, listen, Marco, did you get in okay? Did you fall off again?
Yeah, hi, John.
Oh,
Sorry.
Marco, how you doing?
Hello,
I'm fine enough.
Hello, Marco. Nice to
Nicolas.
see you.
Oh, nice to see you too. Okay. Oh, we're okay now.
Yeah,
some bad news,
whenever you're
unfortunately.
ready. Yeah, Marco, I'd like to introduce you with your face first before you go to your screen share.
Of course.
Yeah.
Let's start now, or you give a countdown.
I don't see it. There you go. Okay, let me get off the spotlight. I'm spotlighting myself, which I love to do. Let me get Dr. Corbulo muted. Okay, Marco, why am I seeing you? I'm seeing Dr. Corbulo. Hold on, I get this screwed up when I do the spotlight. Pin, okay, unpin. Okay, there we go. Okay, Nick, can you talk a little bit to see if the screen goes to you? Nick, just say hi, open up.
Hello, everybody.
The screen's not going to you. It should go to you. It's not.
Nice to be here and nice to...
Okay, there we go. Okay, Marco, can you talk a second?
Again, Dr. Meloni.
Oh, yeah, of course.
Okay, good. It works. Okay, Marco, I think we've got a serious group of people here.
Oh, really?
Yeah, I think so. Okay, so let me introduce you, Marco, and off you go, okay?
Yeah, of course.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good day. This is Dr. John Bennett broadcasting from beautiful Miami Beach, beautiful sunny Miami Beach. This is really what it looks like. We have the pleasure of having Marco Meloni, an Italian neurosurgeon that has agreed to put together a peripheral nerve injury series because he has an interest in that. And I'd like to introduce Marco and let him take over. Hey, Marco.
Hello, John. Hello, all the panelists, and thank you to be here. My name is Marco Meloni. I'm a consultant neurosurgeon in Italy, in the Gravedona Hospital. My interest is about peripheral nerve surgery, and this is a part of a series about peripheral nerve surgery. Glad to be here with all of you.
Okay, Marco, are you going to do a presentation? Are you trying to screen share, Marco?
I'm sorry?
Are you trying to screen share your presentation?
Of course.
Oh, okay.
A moment. Okay, desktop share.
Okay.
Can you see?
Yes, you're going to enlarge it, right?
Okay.
Yeah, perfect.
Okay. Can I start? Or
Sure. Thank you.
Okay. So we are here. This is the second part about a series I am planning about peripheral nerve surgery. In this second part, the topic is brachial plexus, principle of surgical anatomy, semiology, and some features about diagnostic imaging. So let's introduce our main actors of these topics. Madame, Monsieur, the brachial plexus is here. Brachial plexus is a beautiful structure that seem at the first glance very complicated, but I attempt to give you some easy tools to understand the anatomy. First thing we need to know about brachial plexus is that it's made by 5 roots: C5, C6, C7, C8, and T1. Sometimes we can also have a contribution from the C4 roots or from the second thoracic roots. If it's a contribution from C4, we talk about prefixed brachial plexus. If it's from T2, we talk about postfixed brachial plexus. So first things that these 5 root do is anastomosis. They all these roots anastomosis to create trunks. So we got from C5 and 6 a superior trunks, and from C8 and T1 we got an inferior trunks. The only one that stay alone is C7, that create by itself the middle trunks. So we got a superior, middle, and inferior trunks. But probably they are not happy, and so they separate, creating division. We got for every one of these trunks an anterior-posterior division. But what's happened? They decided to anastomosis again, and so they created with anterior division of superior and middles. This, because this is a lateral cord. Posterior division are happy all three, so they join all three, creating the posterior cord. The only one that stay alone is the continuous of inferior trunks that create the medial cord. So we got a sort of love triangle made by the lateral cord, medial cord, and posterior cord. At the center of this triangle, there is this structure that is the axillary artery. That is not only the landmark. In fact, we talk about lateral cord, lateral to the axillary, medial cord, medial to the axillary, and posterior to the axillary artery. But it's also a landmark for the surgeon when we perform infraclavicular exploration of brachial plexus. In fact, here we are in the infraclavicular aspect of the brachial plexus. On the contrary, this part, root and trunks, is the supraclavicular. But these 3 cords still have some argument probably, and they decided to separate. So we got the terminal branches. They bifurcate, so each one of these 3 cords bifurcate to create the musculocutaneous nerve from the lateral cord, and this is the medial contribution for the medial nerve that is made by the medial contribution of the lateral cord and the lateral contribution of the medial cord. From the posterior, we got this nerve that go around the humerus, and so it's called the circumflex nerve or axillary nerve, and the radial nerve. And from the medial, the bifurcation give the contribution to the medial nerve, as we just seen, and the ulnar nerve. So if we think about a sequence of anastomosis, bifurcation, anastomosis bifurcation, we can have an idea how the brachial plexus work. But if it's not enough, we can also remember this. Randy Taylor drinks cold beer, or if somebody of you don't drink cocoa, also coffee black. So Randy as root, Taylor as trunks, drinks as a division, cold as cord, and beer as branches. These are easy and practical tools to remember the anatomy of brachial plexus, the base anatomy. So we go deeper in our description, and we talk about the topographic anatomy. That is the tools need for for the surgeon to perform brachial plexus surgery. First of all, what we have in the anterior view of the brachial plexus. First thing we need to remember in all this complexity of structure is the origin of brachial plexus. Brachial plexus come out from this triangle that is made by the scalene muscle, anterior scalene muscle, middle scalene muscle, and the superior aspect of the first rib. That's create the interscalene triangle. And in this interscalene triangle, we got the roots of this brachial plexus, C5, C6, C7, C8, and T1. And we got in the inferior aspect, this artery that is the subclavian artery. Other things we need to remember is also this nerve. This is the phrenic nerve. This is very important, not only because it is function, because it is the nerve that innervates the diaphragm, so for the breathing, but also because it is a landmark very useful for the surgeon to find the brachial plexus. So just remember this, because we're going to see in detail in the surgical approach description. Other things to remember is also some relationship, like this pink structure. This is the apex of the lung. It is very important because it is in relationship with the last roots, and so tumors from the apex of lung, also known as Pancoast tumor, can create a neuralgia of the inferior roots of brachial plexus. So it's very important to remember this. And other things, they are not in strong relationship with the brachial plexus, but they give some rami, gray rami to the brachial plexus, are the middle cervical ganglion, that is a part of the sympathetic trunks, and the inferior cervical ganglion, that with the cervical thoracic ganglion create the stellate ganglion and give some rami to the C7 and C8 root. So let's see, in this picture, let's have a step back and see the superficial structure, the first structure we find in the brachial plexus surgery. First thing we need to remember is find the platysma, because it's not shown in this picture, but over the platysma, we got what? The sternocleidomastoid muscle. Sternocleidomastoid muscle has two heads, the sternal head and the clavicle head. Clavicle head is the head of our interest for brachial plexus surgery, because going lateral to the clavicle head of the sternocleidomastoid, we got access to the brachial plexus. In fact, we can see here, this is a brachial plexus, is hidden in this interscalene triangle. And to go to the brachial plexus, what we found also? We found this. These are supraclavicular nerve from the cervical plexus. And we got here the homoyoid muscle. Homoyoid muscle is made by two belly, inferior and superior. Sometimes we need to cut the tendons between the two belly of the homoyoid to have access to the scalene muscle that is, you can see here, with the phrenic nerve, and so have access to the brachial plexus. Another structure we need to remember is also the external jugular vein. Usually the worst bleeding when we perform brachial plexus surgery came from external jugular vein, but it's quite easy to find it. So to find it, to ligate and avoid some discomfort bleeding. Let's back to the deeper part of the brachial plexus to find other relationships that are very important for the surgeon. We have just seen the phrenic nerve, and we need to remember also that from this nerve, that is the subclavian nerve, we can also have an accessory phrenic nerve, so a contribution from a nerve that usually innervates the subclavius muscle, but sometimes can give some branch to the phrenic nerve. So it's important to know that to avoid to sacrificate the subclavius nerve, because the effect can be a disaster. Other things we need to remember is also the relationship with the this artery, that is the cervical dorsal trunks or transverse cervical artery. It is important because it gives the dorsoscapular artery, that is a landmark to find the dorsoscapular nerve. And also we need to remember these two vessels, suprascapular artery and vein, that go across the brachial plexus, and they also are a route that help us to find the suprascapular nerve. And let's see more in detail in the following slide. Now, and another things to conclude this topographic description is the relationship with the deep cervical artery. This cervical artery is a branch from the costocervical trunks and has a strong relationship with the brachial plexus, as well as the ascending cervical artery that is here. So we see the topographic description of supraclavicular supraclavicular brachial plexus. Then we got the cord and the branches, and we come into the axillary cavity. Axillary cavity is made by 4 boundaries. The anterior one is the pectorali major, that we can see here in this picture, is cutted and represent the anterior wall of the axillary cavity. Posteriorly, we got the thoracic cage that we can see here is hid by the serratus anterior muscle. Serratus anterior muscle that represent the medial aspect of the axillary cavity, together with this vessel that is the axillary vein, and is another important landmark when we perform infraclavicular exploration of brachial plexus. And we got in a lateral view maybe is not cannot see we cannot see well here. We can go to the other. The lateral aspect is made by of the axillary cavity is made by the capitulongus of the biceps that go throughout the a groove in the humerus that's called the intertubercular sulcus. And posteriorly, we got a series of structure like the subscapular and the teres major muscle, as well as this is the latissimus dorsi. And we cannot forget the subscapularis muscle that can be seen better here in this other picture. Also, we can see better the capitulongus of a biceps muscle. And last but not the least, we go at the center of the axilla, this node of the lymphatic drain, and is not showing this picture, but remember we got also a large fat pad, very important to remember when we perform the infraclavicular brachial plexus surgery. Now let's see the topographic anatomy by posterior view. It's important to know that because when we perform a brachial plexus surgery, we can have a 2 approach. The anterior approach, when we find the structure we just seen, and the posterior approach. Posterior approach that is useful when in patients with some characteristic like they perform already cervical surgery. And posterior view has some advantage, but also some disadvantage for a brachial plexus exploration. Let's see more in detail the topography of this approach. When we perform a posterior approach to the brachial plexus, these are the structure we found. The trapezius muscle that is the first structure we find And to find the brachial plexus, we need to perform a cutting of the trapezius muscle in the median aspect. What we found? We found the rhomboid muscle, minor and major, and the levator scapula. They have in common that they join the medial border of the scapula. And so we need to go over this muscle, but also remember one thing. They are not just muscle, but also some nerve and vessel. And we can see here in this picture, the anatomist moved the scapula laterally, and we found here the dorsal, sorry, I moved this, the dorsal scapular nerve, moment, okay, and this vessel are the arteria and the transverse colli, artery and vein. It's very important to remember this, because if we cut too medially, we can also cut this. And that means that we denervate the rhomboid muscle, and so the patients get out with whinging scapula. This is a very discomfort deficit. This is more detail what we do performing a posterior approach to the brachial plexus, so cutting the rhomboid and the levator scapula in not so medial. We can see here, this medial here, but the surgeon cut here. And after this, what we found is this, the first ribs, and this is the posterior scalene muscle. We also can see here the brachial plexus with the subclavian artery, subclavian vein. And what we can do is to cut the first rib if we need to get more exposition of the brachial plexus. And finally, we go to the brachial plexus in this supraclavicular aspect. This obviously is a brachial plexus with trauma. We can see here the disaster of a scare. And this is a template that has what we find in the brachial plexus. We found like origin from the roots, from the cord. We find nerve to scalenus longus colli. From C3, C4, C5, we find the phrenic nerve. Remember that C3, C4, C5 keep the phrenic nerve alive. We find the dorsoscapular, the long thoracic, the nerve subclavius, and suprascapular, the pectoral nerve, laterally medial, the subscapular nerve, and the thoracodorsal. Let's see more in detail this nerve. The dorsoscapular nerve. The scapular nerve is the first nerve originated from the brachial plexus. It originated from the C5 roots, in the posterior aspect of C5 roots, and give rami to the, the muscle we just seen in the posterior approach to the brachial plexus, levator scapula, rhomboid minor, and rhomboid major. So that's because the denervation of the dorsoscapular can create whinging scapula. Long thoracic nerve. Long thoracic nerve is a nerve that originates from C5, C6, and C7 roots, and is a very slim nerve that anyway has a great importance because it innervates the serratus anterior. Serratus anterior is a muscle we just seen in description of axillary cavity, and joint the medial border of the scapula and joint the ribs from usually from C1 to C9, sometimes also from the 10th ribs. And long thoracic nerve can be damaged in some procedure like thoracotomy, and what's caused this also cause whinging scapula. The suprascapular nerve. Suprascapular nerve originate from what's remember here from the upper trunk, and he came across this notch, that is the superior scapular notch, going beyond this ligament, this ligament, and is a potential point of entrapment for the suprascapular nerve. They come together with the suprascapular artery, but is outside the scapular notch, and they it gave a first branch to the supraspinatus muscle, then go across the spinoglenoid notch, and give a secondary ramus to the infraspinatus muscle. The lateral and medial pectoral nerves, they come from the lateral and medial column, so easy to remember, and they give rami to the pectoralis muscle, pectoralis major in particular, and the pectoralis minor, usually the most part from the medial pectoral nerve. The thoracodorsal nerve is originate from the C8, C7, and C6, C7, and C8, and even if so little, it innervate a great muscle that is the latissimus dorsi muscle. It represents also a potential nerve for reinnervation in the trauma of the long thoracic nerve. In fact, they are very close together. Subscapular nerve. Subscapular nerve originated from the posterior cord, we can see here, and they give nerve to the subscapularis muscle, and also for the teres major, so muscle involved in the mating of the shoulder rotator cuff. And to remember this, I've already told the subclavius nerve does innervate the subclavian muscle, that is this one, the clavicle have been cut off. Subclavian muscle has an action that we don't know very well yet, but probably is stabilize the clavicle. It can be sacrificed, but remember what I just told, the subclavius nerve can sometimes give the accessory phrenic nerve in 36% of cases. So remember this, because cutting subclavius nerves, that can seem an unuseful nerve, can be very complicated for the outcome of patients. Now let's see the surgical anatomy in detail, describing the anterior approach. We already know the topographic anatomy I described. Now let's see what's the surgical approach. These pictures are in cadaveric specimens, and the approach is usually modified outure by outures. We can say that to approach the supraclavicular brachial plexus can be enough a cutting in the superior aspect of the clavicle, usually one finger from the superior border of the clavicle that is represented here between these two white asterisks. In this case, the outure, to have a more exposition, do a cutting like this. So a cutting that's come from the third median to the beginning of lateral third of the clavicle. That is the point where a cutting down go to the deltoid pectoral groove and is approach for the infraclavicular brachial plexus. And the cutting here is usually performed between this point and a line that is in line with the angle of mandible. And this obviously is the median line. What we found when we performed this cutting? We found the platysma. From the platysma, we go over, and we found, after cutting the platysma, this muscle. What is this? Is the head clavicle head of the sternocleidomastoid muscle. And what we got here, we got the first tricks of the brachial plexus exploration, the external jugular vein that have been cutted in the surgery, obviously is ligated and cutted. And so let's go ahead, and what we need to do to explore the brachial plexus, to move medially the clavicle head of the sternocleidomastoid muscle. And what we found here, we found this, that is a fat pad. And also something else here. What we have behind the sternocleidomastoid muscle, we got this, the internal jugular vein. So we go lateral to the internal jugular vein, and we got the fat pad. We also have this, that is the omohyoid muscle, that have been already cut by the author. And so what we need to do is move laterally this fat pad. Move laterally the fat pad, surprise, we got the anterior scalene muscle. We found the anterior scalene muscle. What we need to find again? We need to find this, the phrenic nerve. Phrenic nerve is in strong relationship with the anterior scalene muscle. It is our Google map. Why? Because if we follow the phrenic nerve, we find the C5 spinal nerve. We found the C5 spinal nerve. Okay, so now what we need to do to remember the base of brachial plexus anatomy. And what say brachial plexus anatomy? That from C5 originate the upper trunks, that is created by C6. In fact, we can have C5, C6, and the upper trunks. So let's move down, or better medial, because the patients has the arm, the upper arm in a neutral position, and we got the middle trunks of C7. Let's go over what we have here. Here we have another things we can see more in detail. This is the supraclavicular artery and C8. In fact, let's see more in detail the subclavian artery with the red strips, and C8 and T1 that create the lower trunk. And we can see here also the suprascapular nerve. This is another very important landmark, because we got a C5, C6, we got the upper trunks, and we got the suprascapular nerve, and also the is not shown here, but we got the dorsoscapular nerve. This is a cross of several nerves that is also called as herb points, is another important landmark. So now we explore the supraclavicular brachial plexus. Let's move to the infraclavicular brachial plexus. We continue the cutting in the line we just seen at the beginning, is the deltoid pectoral growth, so made by the deltoid and the pectoral major. We need to go throughout this this growth, and what we found as a landmark, we found this, the cephalic vein. Cephalic vein can be moved or even cutted. After we cut it, we have a fat. Over the fat, we got this. What there is over the pectoralis major is a little boy, the pectoralis minor. When we found the pectoralis minor, we're in the right roads, because we need to dissect the pectoralis minor. Pectoralis minor can be also cutted, and what we got here, we got this, that is the axillary vein. When we got axillary vein, we got a landmark and help us to find the brachial plexus. In fact, we can see here the lateral cord following the lateral cord, we can also already see here the branches from the lateral cord are what's the musculocutaneous nerve and the medial contribution to the medial nerve. And we can find here the other important landmark, axillary artery. Now we have a referral point because here we got the posterior cord. Interesting to see how posterior cord is not really posterior, but is posterolateral to the axillary artery. But for a practical purpose, it's easier to remember that we got the lateral cord laterally to the axillary artery and a posterior cord posterior to the axillary artery. So let's continue. And what's we missed? The medial cord is enough to find at this point because it is medial to the medial posterior to the axillary artery. And now to conclude, we have all the cords, and we can find here the branches: musculocutaneous, median nerve, and ulnar nerve. The posterior approach. We have just seen how the posterior approach works. Let's see more in detail. This is another cadaver specimen. The cutting is made at middle rods between the alba line of the posterior spine and the medial border of the scapula. This is the apex of the scapula, so here the medial border, and a middle rod we perform this cutting. So what we found? We found the trapezius that have been cut in a blunt cutting here. We got the border of the trapezius, so all around here. And we got here the two rhomboid muscle, minor and major. We are in the left side. And so here is the levator scapula. So what we need to do here to cut? Where? Medially? No way, because we got the dorsoscapular nerve and the transverse cervical vessel. So cut here as performed the Ocher. And what we found here, the posterior scalene muscle, and over the posterior scalene muscle and the middle scalene that have been cut here. This is the first ribs. Posteriorly, we got the brachial plexus suprascapular and long thoracic nerve. So we can follow this nerve to find the roots. In fact, we can see here, following the suprascapular nerve, we can find this origin from the upper trunks. We can find here the middle trunks, and here the lower trunks with the subclavian artery. So very interesting approach, but it needs a learning curve and obviously some important aspects like where perform the incision. So now let's see what's a surgeon of the brachial plexus and the peripheral nerve surgery need to know, the semiology. Remember, and I won't be tired to tell you again and again that peripheral nerve surgeon need to know two things in particular. Need to know the anatomy, the surgical anatomy, and the semiology, because there is no diagnostic exam like MRI or ultrasound imaging that can tell you the diagnosis. They are useful, of course, but without the anatomy, without the semiology, you won't get diagnosis. So let's see brachial plexus semiology. I talk about the semiology of the brachial plexus and of the nerve we just see in detail about median, ulnar, musculocutaneous nerve, so the branches of brachial plexus. We see in the next panel about the upper arm peripheral nerve surgery. Here in detail, the distribution of sensory of the brachial plexus. Here is the territory of the C5 and C6. So a lesion of the supraclavicular brachial plexus can give this anesthesia. If we got a lesion of the infraclavicular aspect, usually This is what is involved in the loss of sensation. If there is a complete trauma that is more usual of the wall brachial plexus, we got a summa of this. So we got all the harm with anesthesia, with dysesthesia, not this part because there is a contribution from the thoracic nerve. And let's see more in detail about the motor performance, what we need to examine. The rhomboid muscle that, remember, are innervated by the dorsoscapular nerve. To test the rhomboid muscle, the patient need to keep his arm on the back and push on the back against the end of the examinator. What we found here is the contraction of the rhomboid muscle usually seen in this aspect. Pectoralis major muscle. Pectoralis major muscle, remember, is made by two heads, clavicular head and sternocostal head. Clavicular head is innervated by the lateral pectoral nerve, can be tested at this way. The patients abduct the arm and we ask the patient to push against the hand of the examinator. And we can see here the body of the muscle contracting. Serratus anterior muscle. Serratus anterior muscle is innervated by the long thoracic nerve. Usually, to test the serratus anterior muscle, I ask my patient to put the arms the hands, in front of a wall, push and push. Usually, we can see a contraction of the serratus anteriorus, and in particular, a lateral movement of the scapula. In this case, we can see there is something wrong because the apex of axilla move medially. So there is no contraction of the serratus anteriorus that move the scapula laterally and anteriorly, but there is a contraction, an even more contraction of the rhomboid muscle. So we got the whinging scapula. Pectoralis major muscle, sternocostal head. Okay, we just seen how work the clavicle head. Now sternocostal head is another movement. We ask the patients in the middle position of the arm to move, to abduct the arm, and we can see here the contraction. So we test the lateral and medial pectoral nerve. The infraspinatus muscle is not easy to test, not easy to test, but remember that's very important is we need to keep the elbow of the patients in this position because the patient have to move, to rotate the forearm laterally without moving the arm. Just at this way, we can examine the infraspinatus muscle that is innervated by the suprascapular nerve, as well as innervated the supraspinatus muscle that we test at this way. At middle position of the arm, let's abduct the arm and we can examine the supraspinatus muscle. Latissimo dorsi muscle. Latissimo dorsi muscle is innervated by the thoracodorsal nerves. How we can examine this muscle? In two ways. The first one is asking the patient in a 90-degree position of the arm to push down, and we can also feel the muscle, or we can also feel the muscle, ask the patients to cope. And finally, the teres major muscle, that is part of the rotatory cuff, so we ask the patient to move posteriorly the arm against the hand of the examinator. And also the teres major muscle is innervated by the subscapular nerve as well as the subscapularis muscle. Now, some details about the radiologic anatomy. Magnetic resonance imaging. Magnetic resonance imaging can be helpful when we examine the brachial plexus and we suspect there is a tumor. Obviously, magnetic resonance imaging is mandatory in this case. Anyway, In this case, I want to focalize on the anatomical aspect on MRI of the brachial plexus. What we can expect from MRI is this. In coronal steer, we can have a panoramic vision of the brachial plexus with C5, C6, C7, and C821 that create the trunks, superior, middle, and inferior. Usually the coronal steer is the more useful examination to for brachial plexus. Here in detail, we can see the continuous of the brachial plexus in its infraclavicular aspect. Usually the aspect of the nerve in MRI is this. We got a low intensity signal inside the nerve. In this case, it's a sagittal cutting of the superior, middle, and inferior trunks of the brachial plexus, and all around we got this hyperintensity that usually is the epineurum and the fat that usually go around the brachial plexus. Another very important tools that is so important, I want to dedicate one of my panel to this, is the sonographic imaging. Sonographic imagings can be very helpful for the brachial plexus and peripheral nerve examination in general. That's why, because ultrasound examination has a sensitivity that is 93% respect to 67% of MRI, is also have an opportunity to have a dynamic examination, so to move the arm of the patients while we examine the patient, and so to have an idea if this is a nerve or is a tendon. And also there is the Doppler. So if we need to find the nerve, we can also see the vessel by ultrasound Doppler. The only problem of ultrasound, how we can see here, is that we cannot have a panoramic view of the brachial plexus. So can be quite difficult and need a very long learning curve to be an expert of ultrasound peripheral nerve examination, in particular brachial plexus. But if we remember the anatomy and remember the relationship, in particular the vessel, using the ultrasound Doppler, we can, using some movement of the patients to find the tendons, we can have an idea what we examining. In this case, this is an examination of the phrenic nerve that is, you can see here in this picture. Is interesting to show how the nerve appears in ultrasound. We have a nerve that has several hyperechoic signal inside are the fascicle, and all around we got the hypoechogenic signal are the fascicle, and all around we got this hyperintensity that are the perineurium, the internal perineurium. If you don't know, just see my my last panel. Here we got another experience with ultrasound, and we can see here the 6, 4, and 5 are the cervical roots, and here this black black shadow that is the C7 vertebra. Also, it's very important here to have the ultrasound Doppler, because we can also see the vertebral relationship like this. You can see this root here. This is the it can be the vertebral. I don't have the Doppler, so I cannot tell you exactly, but we can see very well the ultrasound Doppler, the vessel. So we conclude here. These are my reference book. that I strongly suggest you if you want to practice with peripheral nerve surgery. In particular, I suggest you this that is a very helpful tools for semiology in peripheral nerve surgery, and is our other reference. So I conclude here with this beautiful picture. My good friends from University of Michigan, the brachial plexus unit, Mrs. Linda Young, and Mr. Jimmy Cully, that is the man that moved the surgery of obstetric brachial plexus palsy into the United States. Thank you, all of you.
Great, Marco. Thanks a lot. I know we've been trying to get this series going for a while, and I'm really glad we did. I think we have some serious people, I hope, that can interact with Marco. And so any questions or comments, don't be afraid to ask or comment. Okay, the floor is open for questions for Marco. Or comments.
I have one comment.
Okay, Johanna, good day. How are you today?
Hi, everybody. Hi, John, and hi, Professor Meloni. I'm doing fine, and I want to give my best greetings for this awesome presentation. It was really enjoyable, really good points, and really nice tips. Thank you so much. I was looking forward to this. It was my high point of Saturday, I have to say. So thank you so much. I don't have any questions. I just enjoyed enormously. Thank you. Keep these coming.
Thanks, Joanna. Joanna's a neurosurgeon from Finland.
Yes.
Okay, more questions or comments? I know they're out there. Dr. Kubulo, are you there? I'm picking on people.
Maybe I have still one general question since nobody is asking. Yeah.
Sure, go ahead, Joanna.
I was wondering now, because of this COVID situation, how is it, Dr. Meloni, in your country? Is there already now starting with the elective surgeries to put on stall because of the situation, or how is it there? Because here in Finland, they're starting already to put some of the operations, at least in peripheral nerve operations. How is it in your country at the moment?
We are improving. I mean that unfortunately we stopped all the elective surgery. So we just perform emergency surgery or surgery that cannot be postponed over, like could be discal hernia with deficit. Unfortunately, for peripheral nerve surgery is bad periods because peripheral nerve surgery usually considered like surgery that could be moved whenever everyone wants, even after 1 year. Obviously, is not true at all. But fortunately, situation at this point is this. The good news is that from the next week we came from a situation of red area. That means that all the building, all the commercial center are closed, and we cannot move from.
I got that, Marco.
Okay. And we cannot move outside the town. Next week we move in the orange area, so some shop will be available, in particular like haircut, not the restaurant, fortunately, but also some sport activity will be available. In fact, I'm looking forward to take back my golf club. And I hope for surgery too will be more easier to begin again the elective surgery, because I have a long list of patients waiting for surgery, and also peripheral surgery as well.
Thank you, Professor Meloni. Same here, same situations here. I totally agree with you. Thank you.
Thanks, Joanna. Marco, I have a comment. Now, you have an interest in peripheral nerve injuries, correct?
Yeah.
Yeah, you've been to a few conferences. You went to one in Minnesota, one at Mayo, correct?
Yeah, exactly. Michigan and Minnesota.
Can you tell us a little bit about those? Did you learn new things, or were you kind of did you see some interesting stuff?
Yeah, I can give an anticipation, because I have in plans to talk deeper in my next panel.
Oh, okay.
But I just give an anticipation. I saw nerve transfer techniques that are a great revolution in peripheral nerve surgery, because a lot of patients with brachial plexus lesion, that they just have the arms in the air palsy, so they have the arm just like this, and they're able to do more to recover some important movement that help them to be to have autonomy again. So movement like this. So just figure out from a position like this to have opportunity to do this. And so I saw these techniques with a great percent of success, and that's means that peripheral nerve surgery need to be learned, and and deserve a position in the surgery, in particular in neurosurgery, where sometimes it is as the role of Cinderella more than a main role.
In another comment, in most of the world, do neurosurgeons refer brachial plexus injuries to specialists, or do they handle them themselves? Most general neurosurgeons.
Well, usually for surgery like carpal tunnel syndrome, ulnar nerve entrapment at the elbow, large enough number of neurosurgeons are able to do by themselves. But when we talk about more complex surgery, like could be nerve trauma, usually there are some neurosurgeon or some plastic surgeon dedicated to peripheral nerve surgery, and that these people, that the patients are referred. We got in Italy, for example, some surgeon like Deborah Garozzo in Ravenna, I guess, that is a great peripheral nerve surgeon, and usually the most difficult cases go to her.
Mm-hmm. It's probably like that in most of the world. Specialists in certain areas. Okay, more comments or questions from the panel? Geez, I thought this would be a rambunctious group, but you guys are quiet.
We got some comment in the chat, John.
Oh, is there? Okay.
Hi.
Go ahead.
Hi, I have one question. We will operate at more time distal peripheral nerves anastomosis. We can't affect more time. Then we will do nerve transfer. For example, I have more cases, injury plexus brachialis, for example, gunshot, after gunshot. I do sometimes anastomosis, but I can't affect. What need give attention anastomosis operation time? I understand me?
Yeah, I think so. First of all, there is no 100% guarantee of success in the nerve transfer, of course. Anyway, there are some aspects that need to be evaluated before performing nerve transfer. First of all, the availability of nerve, of a healthy nerve, the number of fiber, and also a strong collaboration from the patients, because the only nerve transfer don't work if there is not a physical therapy, a strong physical therapy after the surgery. I have in mind to talk more deeper in my next panel, because I dedicate a panel about nerve transfer and tendon transfer. That is the last land in a nerve lesion when the nerve surgery don't work anymore. But usually in a nerve transfer, those are the tricks to remember, to examine the nerve available, to understand what's the better transfer. We have a lot of opportunity of nerve transfer, but we need to choose in the right way. So number of fascicle, collaboration of patients.
There's one
we will affect neurotransfer, yes. If we can get effect neurotransfer, we will do tendon transfer. Thank you so much. Thank you.
Welcome.
Thank you. Thank you for the question. We have a question in the panel, Marco. Batur Bathistan says, thank you for the presentation. And I don't know if this question is right. How do you think about a medium nerve? It is a steel topically or what? I'm not sure I know what that means. Do you see the question there, Marco?
Yeah. It's a steel.
Does it make sense to you, that question?
Yeah, it's not steel like the metal, I guess. Okay. What does this mean? Still topically or what? I don't understand the question, John.
Batur, are you there? Can you clarify the question? I don't know if you're there or not.
Topically.
Yeah, go ahead, Batur. Yeah, I'm not sure if I understand that question. I guess Batur is not.
If median nerve is I don't know, an aspect of brachial plexus surgery. No, I'm going to talk about median nerve pathology in the following panel. The way about.
Hello. Hello.
Okay, go ahead.
It's me. Like I can't. I just do some research. Start to research about carpal tunnel syndrome.
Okay.
And in Mongolia, I'm reading in very many many studies in America and Russia, and read it, but I can't. It's still a couple topic. How to say? Relief is how to say it? Actual.
Oh, okay. Maybe I understand. You mean if there is something to discover again about carpal tunnel syndrome?
It's enough to study it or not?
Okay. If you mean research about carpal tunnel.
Enough studied carpal tunnel syndrome, or it's injury median nerve.
Injury of median nerve, you mean? There are several topics about this. Probably one is this: what's the time of exploration of nerve? Even in some, usually most authors agree that the time is 3 weeks in a lesion and a synoptomesis. But other things to check about carpal tunnel are maybe the technique, surgical technique. Some authors have get some interesting result with endoscopy. Some other authors say that endoscopy can be advantage because you can just perform a cut little like this. But also we sometimes the endoscopist is not able to cut the whole carpal ligament, and so the recurrence can be behind the corner. Personally, I guess that it's needed a strong and well done review. That's usually depended by the endoscopist. Some people need a more long learning curve to use the endoscopy in the carpal tunnel and to have more idea about the good result of surgery.
Thank you.
Did that answer your question, Bator?
Yeah, okay. Thank you.
Yeah, thank you for the question, Bator. Okay, we have a couple more questions and one comment from Norma, Norma, are you there now? She's on duty. She may have just, are you available? I'll ask your question if you're not around. I guess she's not around. She's on duty. Now, what Norma Sanchez says, she's from Central America, an excellent topic, but in Central American countries where technology is little used to recover the patient in relation to peripheral nerve injury, there is very little neural anastomosis surgery. Rather, it is only left in conservative management. Excuse me for the middle of communication, but I'm on duty for sharing. Thanks for sharing.
Yeah, in fact, she touched a very important point, that the nerve transfer is not still well developed, not very shared by the community. But that's because it's not because it is efficacious. On the contrary, it's a very efficacious. But it need a practice. In practice, you just seen there is an anatomical description that is not common for a neurosurgeon. Personally, I spend a lot of hours, a lot of book studying the anatomy of the axilla, anatomy of the lower limbs. That is not common for me because I was I usually studied the brain, I studied spine anatomy, but I studied the branches of the femoral nerve, the topographic anatomy. Sometimes it is hard to metabolize, and so it needs. I think it is a over speciality apart. If a surgeon is interested to develop at the 360 degree, the peripheral nerve surgery need to dedicate almost 100% to peripheral nerve surgery. That's my opinion. Anyway, that don't mean that some surgeon like Semis, the Iranian surgeon, most famous for the approach to the pontocerebral angle, was also a peripheral nerve surgeon, an excellent peripheral nerve surgeon.
Okay, very good, Marco. Another question from Miguel Lodiero. Miguel, are you there? You want to ask a question? Or I'll ask it if you're not around. Okay, Miguel says it could be interesting to use this type of surgery to perform muscle relaxation in the sequelae of patients with spasticity produced after a stroke.
Usually when we got spasticity after stroke, we got a general spasticity. So peripheral nerve surgery can be not so efficacious. Usually in the patients that came to my attention for general spasticity, we perform the baclofen therapy, and if these patients don't respond very well to the baclofen therapy by mouth, usually we perform intrathecal therapy. So we perform a test with a very small injection intrathecal by a spinal needle of baclofen. If there is answer, usually implant a baclofen pump. But peripheral nerve surgery in the general spasticity don't work well. Usually in localized spasticity can have a role, but for general spasticity, so in particular after stroke, is not efficacious. I prefer to, if there are no contraindication, I prefer to implant the baclofen pump.
Very good. Raj says, are you going to have a talk on brachial plexus surgery? Actually, the surgery itself, I guess. Are you there, Raj? Maybe you could clarify what you want to know. Perhaps he isn't. Okay, more comments or questions from the panel? Hello, Patty. I don't know if Patty from Argentina can tell us about the way that is treated, how conservative is brachial plexus of avulsion are treated in Central America. Okay, any more comments or questions?
If I can anticipate one thing, John, because I see so many questions about peripheral nerve trauma. The next panel will be an introduction to the surgical anatomy and semiology, because as I told, they are the base for understanding of the peripheral nerve surgery. In the next panel, again, I will be more specified about the nerve trauma, nerve tumor, and also reconstructive surgery like nerve transfer and also tendon transfer.
Very good. Okay, last chance for questions or comments before we leave for next week. Now's your chance. Don't be afraid. You know, Marco, people are getting to learn this technology, and I think they're maybe a little timid sometimes, but I think with time, people will open up a little bit more. But thanks for a great presentation. Thanks for taking the time, probably in your day off. I tell you, you know what? I would love to have a talk on Italian food. The heck with medicine. Let's just have a talk on Italian food. But anyways, I'd like to thank you, Marco, and we'll talk later.
Hello, can you hear me?
Oh, okay. Go ahead, Faraz. Go ahead. Go ahead.
I have a question to Dr.
Sure.
Marco.
Go ahead.
I have done several surgeries for carpal tunnel syndrome.
Yeah.
And in my life, only one case I had with the woman who had severe pain while washing hands with cold water. Can you explain or?
After surgery, you mean?
After surgery, yeah.
Those
have subsided after surgery, but still has only pain while washing with cold water.
Yeah, only cold water.
Some kind of parasympathetic or sympathetic.
Yeah, but does she have also dysesthesia in the median?
All disappeared.
All
symptoms disappeared.
Okay, all the finger or just the median nerve territory?
No, median nerve.
Median nerve, okay. And did she perform a regional anesthesia to perform the carpal tunnel or just local anesthesia?
It's local.
It's local, okay. Maybe she could be a response, obviously is caused by sympathetic activity of the nerve. My suggestion is to attempt therapy with pregabalin or gabapentin, low dose, to see if there is some improvement like this. On the contrary, I suggest you to let's see more in detail the maybe by use of electromyography if there is still some lesion in the median nerve, so there is no a real improvement of the conduction, and in this case attempt a re-exploration. I'm very favorable to re-exploration when there is still something wrong, and consider that in a carpal tunnel usually there are some scarring that still pins the nerve and can create still some trouble to the patient. So in this case, it could be very useful to perform a re-exploration. But first attempt anti-neuralgia therapy with low dose. Don't junk the patients with a high dose of neuralgia therapy, anti-neuralgia therapy, because they also can be a problem for daily activity.
Addiction of that.
Yeah, correct. Anyway, if you find it, just perform a re-exploration.
Molto ringrazio.
Prego.
Okay, very good. We have a couple more good questions that I missed. Omar Jabara says, thank you for your time and the great presentation. We always, as a neurosurgeon, facing some difficulties with peripheral nerves because of lack of surgical experience. Orthopedic surgeons used to do these surgeries. What's your recommendation if someone's interested? And peripheral nerves, and they also are asking questions about peripheral nerve surgery fellowships.
Well, there are a lot of, first of all, create the basis. So study the anatomy, perform a cadaveric dissection. In this time, unfortunately, it could be very difficult because the coronavirus pandemic. But when there was not this problem, I performed some cadaveric dissection course. There is one very good in Copenhagen, and it is already open the subscription for 2021. If you want to check for Copenhagen peripheral nerve surgery course, and it's going to be very, very helpful and very useful to understand the true surgical of the peripheral nerve. Is very complete. And also fellowship, you can find some fellowship, a lot of fellowship in the United States, if you have the opportunity to join them, like would be at the Mayo Clinic or the Michigan Peripheral Brachial Plexus program. This is very beautiful, and Linda Young is an excellent teacher. As I told you, you need to dedicate it. Sometimes, and I experience like neurosurgeon, I have to take care of spine surgery as well, because a lot of my patients in outpatient clinic suffer of back pain, sciatalgia, or cervical hernia. So forcefully, I have to find a solution for them. In the case of peripheral nerve in my hospital, are not a lot except for carpal tunnel or ulnar nerve at the elbow, and sometimes also some trauma if I'm lucky, like a surgeon, not like the patient, of course. But you usually perform a fellowship in a good center, like in the United States, but also I think there is a fellowship in London at the Royal National Orthopaedic Hospital under the direction of Mr. Sinisi, and it is also a very beautiful place where I spent 7 months as a visiting surgeon, and is an excellent place. Anyway, if you're not able to perform fellowship, just to go see, like visiting. I just been 2 weeks in United States, Minnesota and Michigan, but 2 weeks were like 2 years of experience, because they not only I've seen a lot, but they also give me encouragement to study a lot the surgery, the peripheral surgery.
Well, how long is it? Go ahead. You have more on the question?
Yeah, I have another question.
Go ahead. Go ahead.
I remember in the past there was a kind of surgery when you have big gap in a nerve, for example, median, ulnar, or radial nerve. Is still that surgery practiced nowadays to suture both ends of the nerve to the adjacent nerve?
When you got a trauma to the ulnar nerve, you mean?
For example, you have a 6-7 centimeters loss of median nerve.
Oh, yeah.
Is it practiced to suture both proximal and distal ends to the adjacent nerve?
Usually, you need a nerve graft, of course. 5 or 6 centimeters are too much to suture both extremities. So usually, you perform like for sural nerve, a nerve grafting. Also remember that more distal is the nerve, more easy is to recreate a continuous by nerve graft. If more proximally, usually the nerve graft don't work and you need to move to the nerve transfer. But usually in case of a nerve trauma with a so great loss of continuity, nerve grafting is the best solution, usually. Maybe I got a picture, if I can find it, about a case I saw in Michigan. I don't find it. Anyway, I can describe you. It was a patient cut at the cubital anterior aspect of the elbow, and it lose function of the posterior interosseous nerve. In this case, the cutting was the patients were referred to us after some weeks. So there was a traction of both extremity and no opportunity to suture by first without grafting. So a graft have been taken by the sural nerve, creating a bundle of nerve of fascicle, and put with fibrin glue and some nerve conductor. I talk more in detail in my next panel. And I don't know the outcome of patients, but usually in this case, you got a good recovery. Obviously, as I told you, everything depends by the cooperation of patients. The patients stay with hand like this, with the grafting, but the hand like this, without doing anything, the recovery will be even less probably.
Okay, thank you very much.
You're welcome.
Marco, how long is a fellowship typically?
Typically for peripheral nerve surgery is 2 years.
2 years, okay. That's quite a commitment.
Marco, I have one question.
Go ahead.
Again, how do you think about the new product of Integra nerve wrap?
I know what you're talking, but I'm not informed about that. But I take a note. Probably in the next panel, I attempt to give you an answer. Integra is the company that creates the nerve conduit. I know exactly, but I'm not informed about that. I'm sorry.
Mm-hmm. It's like just newly product about from Integra. Last week I about this nerve guide and nerve wraps I read. I don't know if there's any practice about this. I think you as a professional about the peripheral nerve and ask you.
Okay.
How's your opinion about this? Is this successful or not? It's just do something.
I check about this project because I don't have any information. I'm listening for the first time of the Integra.
Okay, very good. Any more closing comments or questions? Marco is probably a busy guy. It's day off. I know if I was him, I would go have a big plate of pasta.
Okay, Marco, I can left you my email address. Can you, you know about this? Can you send me your opinion by email?
Great
Of
place.
course.
Write it down in the chat.
Yeah, put it down in the chat. I'll make sure that Marco gets it. Okay, Batura? Put it in the, like you put your question in, I think.
Okay, I left my.
Oh, yeah.
Yeah, I'll make sure I get it. I think I've corresponded with you before, Batura. Oh, I have a general question, Marco. I'm not a neurosurgeon, but my brother recently had a nerve release of his ulnar nerve. And one thing I was very surprised that the neurosurgeon said to him, he stressed very much that he should not smoke.
Yeah.
I've never seen a doctor so adamant about smoking than this nerve release. Why is that?
Because the nerve, how to grow by the vasa nervorum, the vessel of the nerve. So if somebody smoke and close the little vessel of the nerve, the probability the nerve to give blood, to receive blood, and so regrow, literally decrease.
Okay, that's why. Okay, there is a reason for it.
Very hard for a habit smoker, but it's very important as well.
To stop during the surgery, during the preoperative and perioperative time.
Yeah.
Okay, very good. More comments, questions before we close? Okay, very good, Marco. Thanks for taking the time, and we'll see you, everyone, next week.
Great.
Okay.
Arrivederci.
Arrivederci. Grazie.
Bye.
Ciao, ciao, ciao.
Yeah, bye-bye. Okay, very good, Marco.
Bye-bye.
That's
Thank
great.
you very much. Nice to
Good
meet you,
night.
doctor. Thank you.
That's great. Hey, Patty, how you doing?
Hi, John. I'm fine. Thanks.
Yeah, this is Marco. Marco, this is Patty. She's a neurosurgeon from Argentina.
Oh.
You know, I was
Yeah.
going to ask you, Patty. The other gentleman mentioned how in Latin America is treated conservatively because of the high cost, etc. So is the same in Buenos Aires?
I don't.
Okay, lo siento. En Buenos Aires, normalmente, si hay una avulsión o algo serio con el plexus de brachial, normalmente se trata de conservativamente. No opera. ¿Es verdad en Buenos Aires también?
Yeah. Here is the Mariano Sokolovsky professor. Do you know Dr.
You know him,
Marco?
Marco? Does that name sound familiar?
Sokolovsky Mariano.
Okay.
He is a neurosurgery of the nerve periphery, and the treatment is depend.
Have you heard of him, Marco?
For 2 or 3 months.
What's that?
is conservador.
¿Cómo te llama su nombre? Otra vez.
Mariano Sokolovsky.
Mariano Sokolovsky.
Do you know that name, Marco?
No, actually not.
No, okay. Okay.
And what's
Conservador.
and he perform decompression or also nerve transfer.
Here the treatment is conservative, about for 2-3 months.
Yeah.
Less here we have 2 techniques. The for the thoracic nerve or overline.
Okay.
Yeah. So you get an reinnervation from the thoracic nerve, you mean?
Yes.
Yeah. Yeah. I know these techniques. Yeah. There's a also known as a breathing heart. Yeah.
We have a good result with force in the deltoid muscle, deltoid.
Correct. Is in fact a techniques that's very indicated in the renervation of the axillary nerve of the circumflex nerve, because it gave a close topographic as a close topographic anatomy to assess the axillary nerve and renervate the deltoid. I experienced this in London. It was a plastic surgeon that performed this, and I remember patients that recovery the movement like this. Is also known as the breathing arm, because of this nerve it originally innervated the intercostal muscle. At the first patients when breathe as a shot like this. In fact, the physiotherapy learned to teach the patients to have a breath when he wants. So like this.
Yeah. Yes, that's right. Thanks, Professor. Nice to meet you.
Work, Mark.
Thank you very much.
Thanks
Which
for coming,
city?
Patty. Okay, yeah, I'm more, Marco, I'm interested. What nature of injury does causes brachial plexus? Is mostly car accidents that you see the brachial plexus injury? Sports, or?
Yeah. Usually the brachial plexus is caused by
Motorcycles.
By what?
Motorcycle injuries.
Motorcycle, that's the most common?
exactly. Motorcycle in particular, because
Okay.
when there is a hit of the motor vehicle, usually there is not only a traction of the arm, but also the falling down of the patient usually hit the brachial plexus.
Right.
So it is
Earth injury like air palsy.
Yeah.
Hyperabduction, huh?
Exactly. Okay.
Oh, you don't have to stay, Marco. You can take off. I know that I would head to the pasta. I'm getting hungry just talking about it.
Yeah, here is it. Yeah, it is 7:30 p.m.
Yeah, I
Where
know.
do you work, Marco?
First, I can wait. Don't worry.
In which city do you work?
What? Sorry. In
In
city.
which city do you work?
The city is called Gravedona. I write it down. It's in the northern part of Italy. In you know the Como Lake.
Right, near Como, right.
Yeah.
How far are you away from Como?
1 hour of by car.
Okay.
In the middle, there is some town where was the George Clooney house.
Io avevo fatto un'irachirurgia a Roma.
A Roma.
20 anni fa.
Oh, wow.
Con professore Nardi, Pier Vittorio.
Well, 20 years ago. It's probably a long time. So I'm 40.
Con professore Agrietto.
Was La Sapienza.
Di Santo Pertini.
Santo Pertini Hospital. Oh, okay, great.
Santo Pertini Caselino.
Yeah, there is a great neuroscience department there. In fact, my master in electromyography, I got in Rome.
Very good.
Also,
I'm just going to hang out here. Batur, how are you doing? I've never met, I think I've mentioned this before, I've never met anybody from Mongolia. I think I met you before, right?
Yes.
Yeah. Nice to have you here. Thank you for the questions.
Thank you.
So
I'm still not enough to speak English.
No, it's okay. It's all we understand.
По-русски?
Да.
По-русски.
Говоришь?
Дети мои маленькие.
Говорю по-русски.
Я учился в Петербурге.
Это хороший город, конечно.
That's the language of Mongolia. The main language is Russian.
It's
Yeah.
Union Soviet.
Okay.
It's the previous USSR.
No. Not bad. different country.
Oh, is now
It's a-
Mongolia independent, right? Independent or?
Yeah, independent country.
Okay.
A bit. We are located in between Russia and China.
Before it was part of Soviet, right? But now, no, right?
No, not.
Oh, okay.
Yeah.
And on the street, people speak Russian or Chinese or everything.
Yeah. Excuse me. What?
They speak on the street in Mongolia.
Mongolian.
Do they speak Russian, Chinese, or
No. Just Mongolian language.
Mongolian
the
language.
Mongolian language?
Just
Okay.
Mongolian language. Different, separate language class.
Separate totally.
Yeah, separate. Somebody. It's a Soviet time. Our parents go to Russia, and somebody go to India. No, not India. China. And it's like mostly speaking Russian. It's like our age of our parents. Now, almost young people speaking in two languages, like English and Mongolia.
Oh, okay.
Yeah.
So more
No,
people
still
now
now,
speak English.
Same things
You
up.
speak-
Yeah.
Same
Yeah,
things
he
up.
speaks good. You speak good in English.
Yeah.
Not sure.
Right. Okay.
Okay, very good. Okay,
Okay.
I'm going to close this up. Thanks a lot, you guys, and thanks, Mark. I'll send you the edited copy as soon as it's ready.
Thank you very much.
Thank
Okay,
you.
thank you, Faraz. Thank you, Batura. Thank you, Patty. And thanks, Joanna. I don't know if she's still here. Norma, if you're off duty, thank you very much. And we'll
Thank you
see
very
you.
much.
We'll see
Thank you
you in
very
a
much.
week, Marco. Marco?
Well, actually, the next week I'm on call, so in a good time. But the next week,
Okay, 2 weeks.
I'll be available for talking about the upper arm nerve and the cervical anatomy.
Okay, great. In 2 weeks, we'll have that put together with the banner and we'll let you know. Okay, good day, everybody.